So tonight's topic is diabetes equipment, and we would like to thank BD for their sponsorship of this webinar. And now I would like to introduce you to our speaker, Tanya Didick.
Hi, my name is Tanya Didick, and I'm a recent grad nurse from the University of Alberta. And I have had type 1 diabetes for 20 years now. And over this time, I've had a variety of different insulin regimens. I've used pens, syringes, and I had an insulin pump for 8 years. And I'm here today to talk to you about diabetes and equipment. So just a quick peek at what we're going to be looking at. This webinar is we'll go through a brief history. We'll look at glucometers, multiple daily injections, insulin pumps, CGMs, and then look into maybe some future technologies. So insulin was first discovered by Frederick Banting in 1922 in London, Ontario. It was an extract and needed to be injected. So Leonard Thompson was the first patient to receive this injectable extract and felt better immediately. So very brave of him to take an injection when he didn't know what would happen. These sort of research procedures might not pass through ethics committees today. Most people back in that time, once they were started on insulin, they would get one vial, one needle, and a sharpening stone. So you would keep your one needle sharp using your stone. There were no glucometers back in the day. Much of the testing was urine tests. So it's also, I find it important to consider that back in this time when insulin was first discovered, diabetes was so for many of these people before insulin, there was no good prognosis for them, and we've come a long way since that time. So glucometers then versus now. So as time progressed, glucometers were invented with an attempt to measure blood glucose more accurately. They were first mass-produced in the 60s and 70s, and they took a very long time to measure blood glucose, and they weren't that accurate. So today's average glucometer is relatively small and portable, only requires a small blood sample, and usually only takes about 5 seconds to measure blood glucose. I can remember being a kid and having to wait the 60 seconds and counting down and being very excited when the 30-second blood glucose meters were out. So now we're at 5 to 10 seconds. So it's come a long way, even just in 20 years. So accuracy is also improved significantly, but there's always room for more improvement in regard to test strips, and there's still a small margin of error. So one of the things that you can do when you go to your diabetes clinic is you can, when you get your blood work done, you can do a blood test with your meter, and you can also get a blood reading from your blood sample at the lab, and you can compare the two values at your next healthcare provider visit, and you can see how accurate your meter is. So moving on, so there are many, many different brands that offer different qualities. So they're usually all about the same size. They can fit in your purse, fit in your pocket, and they usually just take about 5 seconds. Some might be a little bit longer, and just a little finger poke is usually required for the blood. It's not the size of the top of your finger or anything. So the test strips match the brand of your meter, and some test strips are more accurate than others just based on the technology that they use to test the blood sugar. They come in all different shapes and sizes. Different colors are offered. Some of them glow in the dark, which is really good for those 3 a.m. checks or when you're camping and you're in a tent. Some of them you can charge with your USB. Some of them you can just use batteries. So there are lots of different options. And here we have some of the more common ones that are offered, and you can see like the USB and the ones that plug in. And as you might notice too, all these people have really, really good blood sugar readings. Alright, so next we have our lancing devices. So these also vary by the manufacturer, and they usually just come in the same box as your glucometer. So you have a different setting for the depth of the finger poke. So usually they're on a scale of something like 1 to 5 or 1 to 10, or they have different sizes of blood drop. And usually you can tell just by the calluses on your finger what setting you're going to need. And they also have different needle loading methods. So some of them you don't have to change the lancet, and others are a single-use needle. So some of the pros and cons to this, I know, especially for pediatrics, like being a kid, and one of the incentives to change my lancets was the different colors and changing from purple to orange, purple to yellow. And I know for some of the lancets that rotate through the needles, if you're in a pinch, you can't reuse them, so that's one thing too to keep in mind. So looking at multiple daily injections, so this insulin regimen requires a combination of long-acting and short-acting insulin. So common forms for long-acting include Levemir and Lantus, and short-acting insulin such as Humalog and Novorapid. So how this regimen usually works is you'll have your Levemir or your Lantus, which acts as a background insulin, and is one dose that you give usually at the same time in the morning or at night. And then if you require a meal, or if your blood sugar, if you test and you have high blood sugar, then you'll give your short-acting insulin, so your Humalog or your Novorapid. And so one of the things about this is that there's no set number to how many injections you might be giving in a day. Some days you might give 3, some days you might give 10 if you have more snacks or more like small meals, or if you're constantly correcting your blood sugar. So one thing to note that's a little bit different from this compared to previous insulin regimens is that it used to be more common to be on an insulin regimen with insulin such as like Novolin NPH or Humulin R, which had specific peak times. And it would be really important for people on these insulin regimens to make sure that their meals are timed at the time that their insulin is most effective and is going to be lowering their blood glucose the most. So on these, on this newer, to give your insulin around your schedule rather than basing your schedule on your insulin regimen. So multiple daily injections, you're usually using a pen or a syringe. And here we've got a picture of the syringes that you're typically going to see. So with these syringes, you'll draw up your insulin from a vial and you'll measure the amount and inject into your subcutaneous tissue. So they come in different sizes, typically 30 units, 50 units, or 100 units, and they also have different needle lengths. So these are insulin pens. So they're either preloaded insulin cartridges or disposable pens. And so they're disposable and reusable. And disposable are easier to use because you don't have to load the insulin, but they're also more expensive than the reusable ones. So the pen tip is the one you can see in the bottom corner there, and you screw that on to your pen cap, and you can dial up. So they come in increments of usually 0.5 or 1 unit, and you measure your dose that way. One of the benefits from pens to syringes is that when you screw in this cap and you deliver the insulin, when you push the needle into your skin, that's the first time that needle is being used, rather than compared to a syringe, where the first time you push the needle into the vial and then the second time you're pushing it into your skin. So every time you use the needle dulls, and the benefit of these pen tips is that they're only being used on your skin. So they come in different needle lengths. So 4 millimeters, 5 millimeters, 8 millimeters, and 12 millimeters. Sorry. One more thing to note about the insulin pens is that it's really important that if your healthcare provider gives you an insulin pen for a certain brand of insulin, that you're using it with that type of insulin. If you get a pen for, say, Humalog, the Humalog vial and the Lantus vial are different sizes. So if you go to deliver 5 units of Humalog from your Lantus pen, it won't be exactly 5 units. So insulin pumps are small devices with a fine motor inside that deliver short-acting insulin constantly over 24 hours. So there is no long-acting insulin required. It gives you a basal rate, which is similar to your Lantus. So it'll push out, say, 2 units of insulin every hour. And one of the benefits of this is that everyone naturally has different insulin requirements at different times of day. So there's that dawn phenomena, usually 3 to 5 a.m., where your blood sugar will naturally peak. And what the pump allows you to do is you can micromanage so that you can make sure that you're getting, say, 2.5 units for those 2 hours, and that later on in the day, say you always go low at 4 o'clock, you can drop your basal rate at that time to adjust so that you're not constantly having to have a snack at that time. And then, so you have basal and you also have boluses. So a bolus is a dose of insulin, the same short-acting insulin that you have in your pump reservoir, that's given to cover food or a high blood sugar. So some of the pros to the insulin pump are how discreet it is. It's really easy to give yourself just 2 units to program it into your pump, rather than to go get out your bag and your alcohol swabs and to draw. And they can also be programmed to deliver different amounts of insulin throughout the day, like I was explaining before, and you can administer very precise amounts of insulin. You can also they also keep a record of how much insulin is used every day, which can be uploaded to a computer to look for trends. So you might not have to keep as many log records going. So there is coverage in Alberta through the Insulin Pump Therapy Program, and some of the eligibility criteria includes that you're a resident of Alberta, you have type 1 diabetes, and you have a regular doctor or nurse practitioner that you see. They'll need to give you a referral. You'll have to attend an information session at your clinic, and there's a two-stage assessment by the healthcare professional working at the pump clinic. You also need to have a good understanding of carb counting. So there are 4 main brands of insulin pumps available in Canada, and these include the Accu-Chek Spirit and Combo, the Animus Ping and Vibe, Medtronic, and the Omnipod. So there are other brands of pumps that exist outside of Canada, but there's an approval system and by Health Canada and the FDA. So if you have a friend in the United States who has this pump and it's great for you, well, we might not have it in Canada yet. So these are some pictures of the main brands of insulin pumps, and some brands offer different versions and different features for pumps. So for example, there are some pumps that have meters that link your blood glucose readings to the pump so they can pick it up, and you can program your blood glucose into your calculations on your pump automatically rather than having to type them in. And there are also some pumps that offer different reservoir sizes based on your needs. Insulin is a protein, so we know it denatures. So if you don't need as much, keep in mind that the pump is always attached to your body, right? So sometimes that body heat can denature the insulin. So CGMs, or continuous glucose monitoring. So it is a sensor which is attached to your skin and a transmitter that's attached to the sensor. So the transmitter relays signals to a receiver, which is either a standalone unit or it can be the insulin pump. So based on the brand, it can be either or. So it's important to know that that it is only a collection of data. So you're still encouraged to test your blood sugar regularly, but what the CGM is really effective at doing is looking at trends. So if you see on your CGM that you've been sitting around, like say 6.8 for the last couple hours, and just recently it's showing it's creeping up to 7.2, 7.3, you know, you can test your blood sugar and maybe correct that high before you get up to a different reading than you would have if you were just testing at your regular intervals. So it is only a collection of data, and it's still you that has to figure out which insulin you're going to be giving for that blood glucose reading, or what changes in, say, your bolus. Like say you want to decrease your bolus because you're heading low, you still have to program that in. The CGM won't pick up that data and won't make those changes for you. So these are just some images of the standalone unit. So the sensor is the little white rectangle there, so that's the part that would be attached to you, and then the readings show up on the black monitor there. And then below the two images are the sensors, and then how the CGM shows up on the pump. So you can also say if the CGM reads 13.3 to set off an alarm, or if the CGM reads below 3.8, you can set off alarms. And then that would signal you to do a blood glucose test. So some important points to remember. Site rotation. So injecting into the same space in your body can cause lipohypertrophy. So this can lead to other problems. It can affect your insulin absorption. It won't be as effective. And so if you use the same spot, fat and scar tissue can accumulate and cause a lump under the skin. Sometimes if you catch it right away, the site will sort of work itself to normal, but there can be permanent damage. I actually I find this especially, again, like important in pediatrics, especially for kids who are first learning how to give their own insulin to themselves. You know, they get favorite sites all the time. Well, I'm comfortable giving it in my right arm in this spot. This is what I do. When I was a kid, my favorite spot was my stomach, and I actually still have a spot on my stomach where I can't give insulin because it won't absorb properly. So rotate your injection sites, use all the parts of your body. So using those upper arms, outer thighs, abdomen, your hips, etc. And also talk to your healthcare professional about making sure you have that correct needle length. And so another point about that is to make sure that you're changing your pen tips and not reusing your syringes. So I was part of the med staff at diabetes camp, and we had a 10-year-old boy, and I was supervising the injections and changing the pen caps every time before they gave their injections. And I had one of the kids ask me, he said, like, are you supposed to change your pen caps every time? And I said, well, like, yes, you are. How often are you changing them at home? And he said, oh, well, I usually just use the needle until it bends against my skin. So I would not recommend that. You should be changing them a lot more often, using them only once, because they will dull and you will create damage even if you can't see it in your skin. You're causing damage there. All right. So looking into the future, so some of the up-and-coming technology is an eye contact lens. So Google showed off a prototype in January 2014 of a contact lens that had a tiny computer chip with a glucose sensor. So the idea there would hopefully be to send that data to a receiving device so that you could get a trend of those blood glucose, and a lot more research and work is still needed for this technology. Another one is a wristwatch. So it uses positive and negative ions to attract glucose, and there's a chemical reaction, and the watch would get your glucose reading from this, and it could take readings about every 20 minutes. So another project is a closed-loop bionic pancreas project, which would include 2 insulin pumps, so one with glucagon and the other with a short-acting insulin, and the idea is to mimic a real pancreas. And so the sensor would relay data to the main source, and then the computer would calculate corrections for blood glucose and food intake. So some of the problems with this are that short-acting insulin isn't quite fast enough yet to mimic a real pancreas, and glucagon isn't stable enough yet to stay in a reservoir for long periods of time. So they're still working on that. So on that note, I just wanted to end with a couple main points. So one thing that's always really important to remember is that your equipment is only as good as your user. So it doesn't matter whether you're using syringes, whether you're using pens, a pump, a sensor. If you don't do anything with that information, or you're not using it properly, then the technology isn't that useful, right? So a little story there too. when I was a kid, I shared a room with my sister, and my parents would do 3 a.m. blood tests, and a great meter, would look at the trends, look at the blood glucose, and adjust using that information. Well, one night they almost tested my non-diabetic younger sister's blood glucose. And so, that's the thing, is they could have had all all of the calculations in the pump in the world, but if you're not testing the right person, then, that's another barrier to good glucose control. I have a friend, and her dad has had diabetes since he was 13, so about 40 years, and I had the chance to meet his parents, and I got to show them my insulin pump and talk to them about how the regimens that I was using to control my blood glucose, and it was like science fiction for them. And they told me about how they used to have to boil the glass syringes and use insulin that was derived from pork, and there were all kinds of bad reactions, and their son just struggled so much with it. And I think it's really important to acknowledge that that's within our lifetime. That's within one lifetime that they went from boiling needles. And if you look at what we have now, we're saying only use your syringe once, because that's not good enough. We can do better. And just to know that, just to see how far we can really come in the future. So, on that note, that brings us to the end of my presentation, and I'd like to open it up to any questions. And yeah.
Okay, so everyone.